Welcome back to another episode of What Did the Patient Say with Drs. Dana and Lauren Brindisi, sisters and owners of Carolina Functional Neurology Center. We are bringing you inside information from real conversations we have with patients on a daily basis. We get asked the same questions and want to spread the truth on health and healing because we believe everyone deserves to know the answers.
3, 2, 1. Hi, everyone. Welcome back to another episode of What Did the Patient Say? I'm Dr. Lauren Brindisi, and we are here with Dr. Miret. And today we are going to be talking about biomechanics and the brain. I think this is a really interesting topic because most of us don't really think about what's going on in our brain when we have issues with things like our musculoskeletal system. And it really, our brain controls everything. It controls the tone of our muscles. It controls our ability to move. It controls our posture. And so today we want to go a little bit deeper into some of the biomechanics of that. And I think that's really important for us, especially in our clinics, because we do see a lot of patients with dysautonomias. And there are some comorbidities that patients deal with that do affect their mobility. So, Dr. Miret, let's talk a little bit about the differences between flexibility versus mobility.
All right. So flexibility means that an individual can passively move their joints through a range of motion. So for instance, this isn't like the doctor moving, the doctor is moving their joint through that range of motion, versus a mobility is someone actively moving that joint through that range of motion.
Okay. So someone passively, it's being moved for you. Actively, you're doing it yourself.
Yes.
And what is a stability motor control dysfunction?
So when you compare these two, so when someone says like, I'm really hypermobile, they might be, but when you actually have them actively move their joints through ranges of motion, and so if they have the flexibility, but they don't have the mobility, this is called a stability motor control dysfunction, meaning actively they can't move their joints through certain ranges of motion. So when I'm examining a patient, obviously we've learned through school like passive, active ranges of motion, but then I now compare and measure between the differences. And so when I see like someone passively moving themselves, like their shoulder into flexion, but then I actively move them, and you start to see like thoracic extension, you start to see traps starting to cause that shoulder to come up, or you start to see neck start to retract, they're not able to actually move it because they're going to shove their arm into flexion no matter what you do. But if you start to see compensations, it goes, nope, this is now a stability motor control dysfunction.
Okay. Yeah, I think that's a really interesting topic because anybody that works in the world of biomechanics, we're just trained to see and observe these things. And I think that's really interesting because some patients, you don't know from the inside out, if you go to raise your arm, are you also hiking your shoulder up?
Mm-hmm.
How do you identify mobility dysfunction versus stability motor control dysfunction?
Yeah, so when they so if I'm moving their arm for them and they can't get to a certain range of motion, that's a true mobility dysfunction. Like that is, they cannot move. So when basically in school they tell you, passive equals active, when their passive range of motion and their active range of motion are equal to each other and they're both really limited, that's mobility. That's a mobility dysfunction in itself. And then again, if their active range of motion is worse than their passive range of motion, that's a stability motor control dysfunction.
Okay.
Mm-hmm.
And what would make you want to look at those things and compare them?
Definitely. One, obviously, if someone's coming in with a complaint of, my shoulder hurts, my neck hurts, or my knee hurts, or my back, right? But as definitely if I'm starting to see more stability motor control dysfunction through the system, I'm definitely thinking more brain-based. Because
Mm-hmm.
why is the brain not permitting that joint to move through that range of motion? It can, the joint is healthy enough to go through it, which is why they can passively move through it, right? There's nothing actually impeding the joint motion, but for some reason the brain is not permitting that movement. And so that's where I take a step further And I'll look obviously joint level, but also brain level, and then also through the chain of it all. So am I looking down the chain, up the chain? And so that's why I think it's so important to look into that, because most people will have a stability motor control dysfunction probably 7 times out of 10. And mobility is usually something that someone will have.
Okay.
Usually.
What would make you look at distal or proximal joints to where they might be having some of that dysfunction?
The big one for me is I always look proximal. So I always look to the spine first. That's always first. So if someone has a shoulder complaint, I'll look to their thorax, like their thoracic spine and cervical. And if it's like their hip, I will always look to their low back first. Always. But when I hear like it only hurts when I do this and it's a movement. Now, if it's like a squat, that's a closed chain. Like if it's in their hip, that's kind of a closed chain movement at that point. I'm actually going to look, I'll clear the back first, but I will look distally through the knee and ankle. So if they are having a stability motor control in areas because there's actually more mobility happening down the line, or vice versa. So is their hip actually not truly moving? Is this an actual true mobility dysfunction in the hip? Or so that kind of starts there, but are you having it because of other compensations in their ankle and knee? So I always say to my patients, like, your back's behaving like your ankle should. Like that's where this is coming from, or, you know, your hip's behaving like your knee. And so that's where we're getting a lot of these problems with compound movements. But usually I'll always look proximal, especially if someone's neurological findings are matching up with that specifically.
Yeah, I think that's really interesting to think about. And even just from, you know, a traditional biomechanical perspective, when we look a little more functionally at that, just like Dr. Miret was saying, you could have a problem, you know, in your right hip joint, or, you know, you could have pain in your low back, but that doesn't necessarily mean that the generator is coming from that area. So understanding, you know, where things are not moving so well, where things might be compensating for that or moving too much, can really play a role. I think that's so interesting, even when we look at like cross cord mechanisms. So we've got your right leg, your right lower extremity is really paired with your left upper extremity. And so there can be issues in the left upper extremity that's playing a role in what's going on with the pain in your right hip, which I think is just so interesting for people to understand, because it's just not always as simple as I'm having pain here and that's where the problem is. So I think that's an important thing to note and kind of take home if you are dealing with chronic pain and you feel like you've exhausted some very traditional routes to treat it and it's just not getting better. That's time to really start thinking about finding someone who does, you know, some more functional movement assessments, who looks a little bit deeper at your biomechanics as a whole and looks at that whole body. And then shortly we're going to talk a little bit about how we take that even one step further and go super segmentally to say what's actually going on in your brain. And those are some of the things that we see when we treat, you know, chronic pain conditions that are not responding to any other treatment out there. And that's our next step, is like, let's really look at what's going on in the brain.
I always tell my patients, you can't feel pain unless you have a brain. Like, you can't. Nothing else generates that pain sensation. Your brain is what perceives it. So when we're having discomfort or pain, it's important to look there probably almost first. So
yeah. What are things that can affect the stability motor control dysfunction in the brain?
So I've seen this through kind of a number. So for instance, like cortical dysfunction, like we see a lot of like we're talking like cognitive decline or people with a lot of brain fog, and it's a lot to do with like cortical dysfunction. We'll see their center of pressure start to shift backwards, or people even with dizziness, and that's like a big component to their dizziness. Their brain is perceiving they're in a different area of space and they're having problems with that. You're going to see the body adapt, and they're going to become into this camptocormic posture, which, you know, in traditional or conservative medicine is, you know, upper cross syndrome. And it's like, well, yeah, we understand we're in front of screens all day and text neck is a thing, but brain-based, the brain starts to adapt that way and we start to develop this upper cross syndrome. However, that's more brain-based. And so we'll see like contractures of the pec muscles and shoulders not able to go into flexion. And that can in turn cause a lot of stability motor control in the shoulder. As an example for upper cross syndrome, in the shoulder, I like to explain, is a golf ball on a tee. That's how stable it is. It's a very, very mobile joint. It moves in all planes. So when people are like, I have shoulder problems, it's unless there's like frozen shoulder, arthritis, like other like actual joint problems, it's usually a stability motor control in the shoulder as an example, but that's an example of a cortical problem that is causing the shoulder to not move well. The brain is not allowing it to. So that's one example. I've had others of migraine patients where they have a lot of midbrain dysfunction, and you'll see, your midbrain of one of its many functions has descending pathways onto the flexor tone of your shoulder and hip. And so I've had a migraine patient with shoulder problems, and their migraines always begin there. So once we got that shoulder to move, to have moved better and the brain to allow that, migraines have disappeared.
That's awesome. Yeah, I think that's so interesting to think about what's going on with our vestibular system, what's going on with our frontal lobes, what about the midbrain, and these areas that will change the ratio of flexor to extensor tone. And I think a lot of people can understand this, right? We start in a mostly flexor tone when we're a baby. And then as the bigger parts of our brain grow, because we're mostly like running on brainstem mechanisms when we're little, then the bigger parts of our brain come online and inhibit that so that we have the capability to stand up, right? And use our extensor muscles to stand up.
Yeah.
But just like that, what can happen over time, and you see this as people age, which it really shouldn't happen, but it's become a little bit more normal as we see more cognitive decline and changes in frontal lobe and other cortical activity that then allows this flexor tone to become more dominant. And then you've got grandma and grandpa hunched over like this, right? It has a lot to do with their brain function, but that stuff doesn't happen overnight, right? Those little changes in those ratios are happening over an extended period of time. And these are things like, chiropractors, we've been talking about forever, your posture and what the biomechanics of your spine look like tell you a lot about the integrity of your health overall. And now we have a better understanding of how much that is really controlled by your brain function. And I see that a lot. I think the vestibular piece is really important too. Cerebellar function can cause like global hypotonia. So when we're talking about, flexibility, and we're talking about people who might be hypermobile, it's like, what's going on with your cerebellum? What's going on with your parietal lobe? Do you actually even know where your body is in space? Your parietal lobe takes in that sensory information and has maps where you are. And then that feeds forward to your frontal lobes. So you have an appropriate motor pattern. Well, if that motor pattern isn't right, we've got to go through that whole chain of command to say, like, where is that dysfunction actually coming from? And that's exactly what we do. And we talk about all the time with patients with all sorts of neurological conditions. And we don't think about changes in biomechanics as a neurological condition, but it kind of is. It kind of is.
Yeah, the first part of our exam, is just looking at the patient. You'll see head tilts, you'll see rotations, you'll see people who are hypotonic, like you just said, like they'll be recruiting into their core a lot. They'll be kind of, you'll see their core start to activate or their neck starts to really get involved, like all those midline structures. And that already says like, I wonder what's going on with that cerebellum. I wonder what's going on with those midline structures. They look very high, like very low tone, very flexible on the table. It's like, well, if they're very flexible, I wonder how they're stabilizing. And so that is a lot of our demographic with, EDS patients and stuff. And so it's important to look at it from both angles.
Yeah, definitely. We talked a little bit about some cases that this has come into play. Do you have any other examples of things that you've seen, that were more of a biomechanical complaint that really led to what's going on with their nervous system?
Yes, I've worked with some like athletes who, this is kind of like the cream of the crop of physiology, usually, and they'll still be in pain, or they can't really even describe their discomfort. They're just like, I'm used to my body working X, Y, and Z, and it's not. And this is where we get really nitty gritty with both brain and biomechanics. And so for some patients, I've done both. Like I'll do an in-depth like functional movement analysis, and I will, compare that and overlook that with their neurological findings. And so I've seen some athletes who have like cerebellar problems, like as you said, they don't actually know where they are in space, and they're having a lot of these stability motor control problems. But for them, it's degrees of a point versus like someone with maybe a more severe neurological condition where they can't really move at all. So I kind of narrow it down with those cases and get very like nitty gritty, especially since they're loading their tissues every day versus some patients who we see are like bedridden. They're not loading their tissues versus some who are weightlifting or doing other things. And it's like, this is when they're having their discomfort, is once they're loading. So that in those cases, I'll actually have them load the tissue in front of me, or we'll do exercises while they are doing it. So I'll incorporate both.
Yeah. A more extreme example that I have seen, which I think just attests to this when you think about more severe cases, are patients with Parkinson's. Before they even present like they have Parkinson's, that degenerative process has been going on for years and years and years, like often, 10, 20 years. And one of the things when you look retrospectively at what was happening with that patient throughout their life is unexplained shoulder pain. So someone gets shoulder pain. I mean, who hasn't maybe experienced shoulder pain once in a while? Everyone's pretty active. Like you said, these joints are super mobile, but there's a lot of reasons you could start bearing a lot more like strain on your shoulder.
Yeah.
And no one's going to think about their brain if they've got shoulder pain, right? They're going to go, what is going on with the joint? What about the muscles that stabilize my shoulder, the tendons, the ligaments? And I see a ton of patients that come in with shoulder issues who are like, I've gotten x-rays, I've gotten, ultrasound, I've looked at what's going on with my actual shoulder, and there's nothing there. Like there's nothing wrong with it in that space. And again, in these extreme cases, you don't want to automatically think someone has Parkinson's just because they have shoulder pain, but it could be related to the areas of your brain that create the stability in your shoulder, which I think is very important. And something like stress, right? You get in this strong chronic stress response and you're in this more fight or flight state, you are going to have increased flexor tone. And that in itself, right? Your breathing biomechanics can change, and you can be creating shoulder pain that is related to, again, your brain and your stress responses.
I'll also take a look at when something's like chronic or always getting re-aggravated, and like, let's say everything's kind of looking clean on a neurological scale, I'll check primitive reflexes. And I have seen a lot of shoulder, just like with an ATNR reflex, every time they turn their head, right? That's driving. Every time you turn your head and your arms are moving, like that's driving. And so the brain's going to consciously bring that shoulder back to keep the steering wheel, as an example, level, but you're turning your head all day long driving. And so I have seen that a few times.
Yeah. Or you have vestibular dysfunction, and every time you turn your head, you're like miscalculating what you're doing. So your brain is going to just like contract all of this. So you go and turn, and you're just getting this like chronic activation of this musculature when you go and turn your head. It's just little things like that. And then all of a sudden you wake up and your neck's locked up, and you're like, man, I think I slept wrong. I just woke up. I couldn't move my neck. It's probably something that's been brewing for a while, and there are other things we can look at, like your vestibular system and your eye movements. We get a lot of referrals from other chiropractors who are seeing patients, especially with like headaches and chronic neck pain, who they would expect to have gotten better by now. And there are those patients who, right, they come in and they're like, I get adjusted, I feel great for like an hour.
And then it comes back.
It comes right back, and it comes right back. And that's when we really want to look, like I said, super segmentally, what is going on with the areas of the brain that allow you to properly control what's going on with your neck. And that's a lot of pieces to that. So
yeah,
all those things we already talked about, your vestibular system, your eye movements, your cerebellum, your frontal lobes. I mean, all of these things we can look at in the chain of command to say, can we pinpoint where that dysfunction is coming in and why that is altering the biomechanics of your neck when you're moving around?
Big time, especially with adjustments. I know we were going to talk about like when and when not to adjust, or like when do we start incorporating those adjustments with these cases. And I mean, adjustments are fantastic as they put more motion into joints and they send mechanoreception up to the brain. And with mobility dysfunction, depending on what is, causing the mobility dysfunction, it's usually very warranted. But with those stability motor control cases, I take a little bit more of a conservative approach with our adjustments, just because, like, as you said, like gaze stabilization, a lot of times you'll get like a problem also with the neck. And if gaze is unstable, that neck is moving too much. Or when people are like cracking their neck because they're getting chronic tightness, it's usually because the neck's moving too much, and every time they crack their neck, they're shoving more motion into a system that is unstable. So in those cases, it's like you're having a stability motor control dysfunction of your neck, and and that in turn with your gaze instability. I'm not going to adjust your neck right now. As we stabilize, you're no longer going to have that dysfunction, and then you may actually be like, okay, we can actually warrant some adjustments at this point. But that's an example of when or when not to adjust with a stability, like motor control dysfunction versus mobility. But that kind of depends on the case sometimes.
If you haven't watched our episode about not cracking your neck, I highly recommend you go back and review that. So we're talking a little bit more detail about why that is not a good idea, but Dr. Miret really nailed that in terms of you're actually already too mobile. So you're adding fuel to the fire. I think a lot of our viewers are probably waiting for us to talk a little bit about EDS, because we do have a lot of patients who have that or think they have that. Maybe they don't have it, but they do have, hypermobility issues. Let's talk a little bit about that and how that relates to some of this stability motor control.
So EDS obviously is, these individuals have a ton of flexibility and a lot of mobility. Their ligaments are lax, and basically most of their connective tissue is lax, depending on the type of EDS someone has. And so because there's so much movement in these joints, right, that is sending so many signals to the brain, like we're moving around too much, and that's not a stable position for the brain. And as a protection mechanism, it causes a lot of pain, and it causes a lot, or you'll see muscle contractures, you'll see these muscles try to like dance and turn on and try to stabilize these joints as best they can, which can also cause quite a bit of pain for these individuals. And so this is an example where a mobility dysfunction is actually the root cause, but it's causing a stability motor control dysfunction. And that's what's causing their pain, is a protection mechanism of the brain trying not to move through all these ranges of motion, which is why for these individuals, you want to reteach the brain that it's okay to move in certain directions, but you have to teach it to stabilize properly through them. And these individuals rely on their mobility and they rely on their flexibility. And I see this even beyond just EDS patients, but I know EDS is very big in the dance world and gymnastics world. And so I've seen it in those athletes as well, who may have some hypermobility or even EDS, but in those sports, it's great, right? Because that's what the sport demands. And this is where individuals rely on it to meet the demands of what they're putting their body under, such as those sports, but they're actually having a stability motor control dysfunction, and they're not able to stabilize or properly brace their spine or their neck or even the smaller joints, and then they're still doing their everyday life, whatever that is.
Mm-hmm. So what are some things you do with patients who have some of these instability issues related to flexibility or related to this genetic condition that might increase their susceptibility to ligament laxity?
With these patients, obviously our most of our demographic is dysautonomia, and with that we see EDS and other things. So I always explain to patients is I want to get them against gravity as best we can, obviously from a neurological standpoint, so they're not having those dysautonomia symptoms. But for the EDS standpoint is I will start them supine, and we start with basic core strengthening. So that's from breathing to passive core. So for instance, I may be forming the resistance and they're having to brace their core. We may be doing some very, very light shoulder stabilizing exercises. This depends on the patient because, for instance, if these patients are having a cerebellar dysfunction, I'm not going to use a ton of isometrics with these patients, as we know that can affect that vestibular system and the cerebellum on that side. So it does depend on the individual, but I do like to use some isometrics or very gentle stabilizing exercises that they can do first supine, and it's something that you can progress as they're able to get against gravity more and more. And oftentimes I'll work with physical therapists in the area that specialize in EDS and understand the limitations of like dysautonomia and POTS or other types of dysautonomias, and we work together to do that.
Awesome. So aside from a condition like that, what are some other causes of true mobility dysfunction that people might see every day?
Arthritis in our older generation. So something actually impeding the joint itself will cause a true mobility dysfunction. So an arthritic change in the joint as well. I've seen this with whiplash incidents. So we'll see that with concussions quite a bit, right? As we know, we don't have to hit our head in order to have a concussion. So we'll see them post like motor vehicle accident. They'll have that whiplash accident and their whole entire neck will just lock up. And so it causes a mobility dysfunction because passively you can't move them, actively we can't move them very much, and they're equal to each other. And so you'll just see the whole neck tighten down in response to the injury. And we know from a brain-based perspective, like what can be contributing to that in addition to the trauma that's happening to the cervical sprain and strain. But so I'll see that in those incidents as well.
Yeah. So it does get complicated when it comes to something like pain, like instability, changes in your posture and your biomechanics. You know, there's a lot of tools out there, and that's great. We have so many resources, and, you know, everybody at some point in their life is going to experience some kind of pain. But when you deal with these more complicated cases, I think the take home here is to understand that if you're not finding something actually wrong in the joint, in the muscle, in the tendon, in the area that you're experiencing the pain, that you look a little bit deeper, that you start working with someone who's going to evaluate your physiology, evaluate your biomechanics as a whole, take a look at your brain, really, just like we talk about all these other conditions, try to get to the root cause of why that is happening for you, which might be very different than the next person who comes in experiencing similar symptoms.
I'd also say if someone's getting recurrent injuries, like always getting shoulder tendonitis, always getting golfer's elbow, it just keeps happening. Mm-hmm. Even if you're, we understand you're going back into your sport or you're going back into your activity and that may be re-aggravating it, but if you've rehabbed properly, it shouldn't be getting re-aggravated. So then that also, that's more of a chronic situation or chronic injuries or injuries that just keep cycling back in. My question becomes what's going on in the brain? Why is this happening? Because if it has been properly addressed, then it shouldn't be reoccurring.
Yeah, I think that's a really great point.
Mhm.
Do you have anything else you want to touch on before we close out this episode?
No, I think that's it. This was fun. I like this stuff quite a bit.
Yeah, I think there's even more that we can delve into when we're talking about specific areas and these functional movement assessments and areas of the brain and what type of symptoms people might present with. It might be fun to go delve next year a little bit deeper into this area. We can do a little bit more nitty gritty on this topic. If you think that's a good idea, please let us know. Please comment, like, share, DM us if there's a specific topic you want us to talk about. You guys are driving the conversations that we are having, whether that's out here online or our patients in the office. So we want to make sure that we're answering any questions you guys have. We hope you have a good rest of your day. Dr. Miret, thank you for joining me, and we will see you guys next time.
Thank you so much. Have a good
Bye.
day.